Hello and welcome. We're pleased that you've joined us for today's session, One Big Beautiful Bill Act, Tax Implications, Healthcare Roundtable. Before we get started, I wanted to acknowledge our big news that Moss Adams and Baker Tilly have joined forces to redefine accounting, tax, and advisory services for the middle market. It's really exciting, and you can read more about that from the link in your console. And now I'm going to play our housekeeping video.
Welcome and thanks for joining us. Our webcasts are designed to help elevate your business performance. Transform your future for the better with advisory solutions tailored to your vision and supported by our collective technical resources. Our presentation will start in a few moments. Before we begin, here are a few things to keep in mind. You can customize how you both view our presentation and interact with the presenter. For better viewing, close all other applications and turn up your speaker volume. You can also adjust window size and placement or enter full screen mode using the controls at the top of the window or dragging the bottom right-hand corner to resize. At the bottom of your screen, you'll see a series of icons, each relating to a different aspect of our session. You can download the group attendance sheet and a PDF copy of today's slides from the slide deck and handouts widget. You can ask our presenter questions during the webcast by typing a question in the Q&A window and clicking Submit. We'll do our best to answer all questions during the presentation or follow up via email. If you experience technical difficulty during today's presentation, refresh your browser by hitting the F5 key. Today's session will offer you 1 CPE credit. To receive credit, you must meet the requirements as specified by the National Association of State Boards of Accountancy. You must attend at least 50 minutes of the session and respond to at least 75% or 3 of the 4 polling questions, which we'll ask throughout today's presentation. Polling questions will appear within the slide window. To participate in the polls, please click on your answer and be sure to hit the Submit button to record your response. We'll track your progress and alert you when you've earned CPE credit. You can then click the certificate icon in the CPE Progress widget and download your CPE certificate. Don't worry, if you can't download your CPE certificate today, we'll email a copy to you in 2 weeks. If you're attending this webcast in a group, you must complete our group CPE attendance sheet to receive credit. The attendance sheet is available in our slide deck and handouts widget. Please have all group members sign it and send only 1 sheet per group. Also note that CPE credit only can be awarded to participants registered as themselves, and isn't available for participants who view the on-demand version. As a reminder, the presentation you're about to see is not legal, investment, or accounting advice. We encourage you to seek the counsel of a professional service provider to apply this content to your specific circumstances.
All right, we have a great lineup of speakers with us today for our healthcare panel discussion. Their bios and contact information are located in your webcast console. And now I would like to turn the floor over to Chris Bell to get us started.
Thank you, Amy, and it's wonderful having everybody on this webcast. We're thrilled as Baker Tilly to have many healthcare clients across the country in the hospital, long-term care, medical group, dental, insurance, and many other areas of healthcare. And as we've been talking with our clients, many questions about the recent tax legislation have been coming up to the surface. And not all of them are tax related. Many of them have to do with the revenue aspects of the One Big Beautiful Bill Act. And so we put together this webinar to do a deeper discussion around the revenue impacts, some of the tax strategies and considerations for both for-profit and tax-exempt organizations, and some other key takeaways. We hope you enjoy it. I want to give one item of fair warning. Of the 4 polling questions, 2 are at the very beginning of this presentation. So if you're in a time zone where you're eating lunch right now, it's time to set down your lunch for just a moment and make sure you get your CPE credit. With that, we have an agenda here today. A brief background, I lead the Baker Tilly Healthcare Tax Practice, and all of my clients are in the healthcare space. I focus on for-profit healthcare, but we have people both from the revenue side of the house as well as tax-exempt and for-profit tax experts that will be on this call. Little bit of background on this bill. In December of 2017, the Tax Cuts and Jobs Act, sometimes called the TCJA, was passed. As part of the political negotiations around passing that bill, many of the provisions were temporary. They were set to expire, even though members of Congress fully intended for those components to be extended at some point in the future. They did have a sunset. Many of them were set to sunset in 2025 and in 2026. And so if action had not been taken this year to do some sort of tax legislation, there would have been an extraordinary increase in tax burden across our taxpayers in this country. And so both Democrats and Republicans in the last presidential election and congressional elections ran on the idea of extending many of the tax policies from the TCJA. Now, it looked different under the Republican versus Democrat plans, but both ran on some version of extending the legislation. This was done through a budget reconciliation process, which allowed them to pass it with only needing a simple majority in the Senate. So they only needed 51 votes in the Senate to get this passed. There was a lot of wrangling through that process. The initial House bill was passed in May. The Senate bill was passed on July 1st, and promptly thereafter, the House ratified it, and then the president signed it into law on July 4th. It's sometimes referred to as the One Big Beautiful Bill Act, which is quite the mouthful. In today's call, we're just going to refer to it as the Act or the Tax Act. And with that brief introduction, we have our first polling question. Amy?
All right, thank you, Chris. So the first of 4 polling questions: do you currently receive Medicaid direct payments from your state Medicaid program? And your options are A, yes, B, no, C, I don't know, or D, not applicable to my organization. And the polling questions are located right on the slides that we're presenting. So if you can't see it, you may need to hit the F5 key to refresh your console. And then you're going to click the button next to the answer you choose and then hit submit. All right, everyone's pretty quick with this one. Here are the results.
Wonderful. Well, it looks like we have a majority of folks on this call who do receive some form of Medicaid directed payments. Let's move to the next polling question. And again, want to make sure everybody gets credit for attending today's webinar.
All right, the second poll is, do you currently serve a large population of Medicaid recipients who will not meet the OBBBA Section 71109 definition effective October 1st, 2026? And your options are A, yes, B, no, C, I don't know, or again, D, not applicable to my organization. And then while you're responding to this second question, you do have the option to submit questions to our panelists through the Q&A window. We will do our best to work them into our conversation, and if not, we will follow up with you afterwards. All right, a few more seconds here. Make sure to hit submit so that it registers. And here are the results.
Okay, so a mix and a number of people who aren't sure. One of the areas we want to make sure we cover today is so when people come away from the webinar, you have a clear understanding of this provision and how it might impact your organization. I'm going to turn the next part of our discussion over to Eric and Keith to really dive into some of the federal healthcare spending impacts that came out of this tax legislation and how they'll impact our healthcare clients.
Thank you, Chris. I'm Eric Lucas. I'm one of the leaders here in the consulting practice that provides reimbursement services to healthcare providers. I'll let Keith introduce himself as one of the other leaders in that group. But I wanted to kick this off to kind of set the parameters over what is a very complex bill. There's a lot going on here, and there's certain things that I think would be really helpful to kind of digest all of the information that's coming out in relation to these provisions. The first I want to point out is the timeline itself, because what's probably I've seen the most kind of written about at this point is exactly when these things are ultimately going to start impacting providers. And each provision that we're going to talk about today actually has a unique implementation process that it's going to have to go through. Most of the items that we're going to talk about today aren't actually going to impact providers right away. A lot of this will happen 2028 and further down the road. But there are things that are starting immediately, and we'll try to point those out as we're walking through this process. But in most of the cases, the items we're going to be talking about today are Medicaid cuts or Medicaid provisions. And Medicaid is a state program. This is federal legislation that's been passed here, but ultimately the states run their Medicaid programs under federal rules. It's a federal state funded program. So the states are now going to actually have to take the information from this legislation. There's probably going to be some rulemaking on some of these provisions as well, and they're going to have to address those changes in their current legislation. So the process could take some time here before we have some certainty as to how it's ultimately going to be impacted. The other point I'd make here is, as each state is very different in how they've set up their Medicaid programs and how they're going to be impacted by the provisions of this bill. Some have far more exposure on issues. We had a question about directed payment. It's a perfect example. Some have a lot of exposure in this area where some states don't have directed payment programs and they won't be impacted at all. Or to that point, sorry, I'll try to speak louder. I hear that I'm not coming across loud enough. Or to that matter, they don't have as much exposure as they might have compared to other states. So it's important when we're hearing or seeing write-ups coming into your inbox that are talking about these impacts, to recognize that each state is very unique in this, and your state might not actually have the same impacts that another state might have. So it's important to move that through. We're going to talk today about 5 specific provisions in this bill. That's not all of the provisions, but these provisions make up 85% of the cuts that we're seeing to healthcare providers. There certainly is some advantage to digging down deep into some of these other ones, but most cases they're not going to affect the broader state hospital communities. So focusing on these, I think, will probably give you a better idea of the big items that are going to be hitting hospitals. To that point, when I say, as I mentioned earlier, we're talking mostly about Medicaid here. We will talk about some of the other programs, but most of the cuts that we're going to be talking about through this act are through the Medicaid program itself. And yet, when we talk about cuts to Medicaid, and here we're talking about cuts to supplemental payment programs, we're talking about potential rate cuts, and we're talking about eligibility and participation issues. These are all things that are going to have pretty dramatic impact or swings to providers' payer mix as it is right now. And once we start seeing changes there, we know it's going to impact other things like Medicare reimbursement or access to programs like for nonprofits, 340B savings programs. So we have to recognize that Medicaid is kind of an entrance to a lot of other things that it impacts. And so there are downstream effects. We won't be able to address every one of those as we go through, but we will certainly try to as we go through this. But let's get right into this, into the first cut itself, and that is provider taxes. Provider taxes are frozen at no more than 6% for 2 years, and then the reduction of 0.5% each year until the limit reaches 3.5% by 2032. What is, Keith, a provider tax, and how does it impact state Medicaid funding?
Thank you, Eric. Just real quick, I'm Keith Hutcheson, and I'm a principal in healthcare reimbursement. And you have my bio if you want to read more. So provider taxes, big item in the Medicaid savings / cut, depending on which side you're on. The provider tax are really a Medicaid funding mechanism. The federal government pays approximately 70% of all Medicaid costs, even though you hear that Medicaid's a state thing. 30% comes from the state on the remaining basis. That's a nationwide average. States have provider taxes on a variety of services, such as nursing homes, hospitals, intermediate care, managed care organizations, and more. There are actually 45 states with hospital provider tax programs. There are 46 states with nursing home provider tax programs. Alaska is the only state without any provider tax. So, and just a note, yes, the nursing homes and intermediate care, they are frozen. They do not get included in the reductions that Eric mentioned, declining to 2032. So what do the states use the provider tax for? Well, they use it for a variety of things. Some of them use it just to help fund the base Medicaid rates and then maybe supplemental payments. They use them for to keep from having to cut benefits if their states financially are doing poorly, or they've used them to expand benefits, or possibly even with the ACA Medicaid expansion. So the provider tax are based on revenues a lot of times. Some states use a flat tax for maybe a bed tax, they call it, or inpatient. So the taxes are really used to help Medicaid fund everything. So when you hear about one program, there are many things they use this money for. So what would they do if we don't have this tax, or it gets reduced greatly, which it's heading to? Reductions in Medicaid eligibility. There could be payment reductions because I can no longer afford to pay a higher rate. Maybe fewer covered benefits. I know a lot of states that have used it to expand dental or mental health or some things like that. Or they may, if it's important enough, they may have to raise state taxes or one of their other taxes they can raise. So it is a very big deal from a funding level, Eric. And one of the biggest things used to produce out of the taxes is state-directed payments. And the Act is revising the limits on state-directed payments, a large cut there. What kind of cut should the states, which we just said, a lot of them are in directed payments, what should they expect?
So this is definitely an interesting one as far as how states are going to ultimately respond, because as Keith indicated, the provider tax is usually the main mechanism for funding a directed payment program, a directed payment program being a supplemental Medicaid payment on top of the payments that they normally would receive. We have 29 states that are currently running a program like this. There's a few others that have submitted to start programs that provide or starting direct payment programs. They're although unique as far as what they're ultimately doing, but the one thing that has been called out by Congress is that several states are paying supplemental payments at 90% of the average commercial rate for within the market, and whereas others had capped that at Medicare. And for those who follow Medicaid usually cannot exceed Medicare. It's kind of a cap that's usually there, and the supplemental payment had somehow found a way to, or had formulaically found a way to actually pay above that. What this program is ultimately going to do is bring those hospitals or those states that expanded beyond Medicare back down to Medicare. But that's not all of the story. That is only for the states that expanded Medicaid under the Affordable Care Act. If they didn't expand Medicare or Medicaid, I'm sorry, then it's 110% of Medicare. So there are going to be differences between those states that expanded and those states that didn't expand. This doesn't happen overnight. Those programs that have been grandfathered in, they will be able to maintain their current rates until January of 2028, at which point they will start seeing a 10% per year reduction to bring them down to Medicare. Now, the other part of this, though, is messing with the tax side, and then you're going to change the revenue side. That's going to dramatically change the way these programs run and how these programs work. And the question then becomes, okay, number one, is the state, like Keith said, going to fund it through state taxes or through shifting dollars from other programs, or are they going to have to make dramatic changes to the programs because too many hospitals are losing under these programs? It ends up draining too many resources from other hospitals in its effort to shift more dollars for Medicaid. And so we're going to see states having to huddle back together to figure out whether these programs are still viable in the future, or what type of changes need to be made to actually make them viable. And so having said that, though, I would stress the importance that these programs have done. I think Keith already mentioned some of the expansion that was offered, and the dollars that went into rural communities from these types of programs, or to offer those specialized services that Keith had mentioned. Those become at risk under these types of situations. So right now, recognizing that the states are going to have to pick this up and figure out how to solve the problem going forward is going to be a big issue here. And I would also point out that the hospitals that are probably at most risk under these programs are those that have heavy Medicaid volumes right now. DISH hospitals, safety net hospitals, hospitals in rural communities, because these programs, in a lot of cases, were used to kind of help sustain hospitals within rural communities. And then hospitals that run trauma centers, because there was additional funding that was able to be provided in order to maintain those type of programs. And those type of hospitals are probably at most risk when we look at changes that are going to need to be made to these programs. So let's talk about some of the other changes, Keith, because I think the one thing that we heard a lot about in the news while this bill was being crafted is the requirements related to who gets Medicaid. Section 71119 requires 80 hours of monthly community engagement and is projected to result in Medicaid spending cuts of $326 billion. Why is that?
Yeah, this one, Eric, is really sort of interesting. First of all, it's not immediate, but it's pretty soon. It's supposed to take effect on January 1 of 2027. And then there's some hardship things. You could possibly get some extension. But this is really, I think we do have one or two states that have done something of this nature. And what it's looking at is your non-disabled adults that are in the range of 19 to 64 to have 80 hours of work, volunteering, education in the month prior to their service. So we see this creating a lot of hurdles for individuals and really for the state. But, some of these people may have fluctuating employment, like Maybe they've got something this month or this week, but not the rest. They may have caregiving responsibilities, children, adults, whatever. And I think rural gives us some issues with, is there work in that rural area? Is there a place to volunteer? Those kind of things. And then just thinking about this, the increased paperwork and reporting, and how smoothly is that going to go? So we think a lot of these issues could lead to disenrollment. And with that comes, that's bad for all the people that were receiving that service. Now, what's bad for the providers is fewer covered patients. Those, like you said before, vulnerable populations. FQHCs typically have a lot of these patients. FQHCs, some RHCs, they're in vulnerable areas. There's a lot of FQHCs in census tracts in urban areas that have a ton of Medicaid patients. So all of these entities are going to get hit with reductions. And it's reductions maybe because the paperwork's not doing well, or someone just gives up and doesn't do it. So there's a lot of issues here administratively and logistically. And I think it's going to be really big. And it's also going to be, once again, a thing that leads to more uncompensated care with patients that used to be on Medicaid, Eric. So keeping in line with that, we have some other issues. What about the provisions on savings to Medicaid program from the Biden era? 23 and 24 regulations were passed. Have they really taken effect, and is this really a savings?
It is, in that these were acts that had been passed to find efficiencies within Medicaid and the CHIP program and some other local healthcare programs or means-tested programs. Biden had passed a couple different provisions that would ultimately make the eligibility smoother, make the whole redetermination process better, and it would align the renewal requirements. And then also they had a provision that was going to automatically put low-income seniors into the Medicare savings plan. I've been dealing with the bureaucracy related to all of that. So these are provisions that were set to go into place. So they were in the budget. So postponing them like we are to 2034 is delaying what ultimately is a cost for doing this. And quite honestly, that the cost is the efficiencies would have put individuals into these programs more effectively, ensuring that they were getting the coverage that they ultimately needed. It would reduce the work on the provider side to make sure that there was that they weren't having to chase down enrollments and that there was coverage for these individuals. And now ultimately this is going to be delayed. There's going to be the same struggles that led to these provisions being put into place in the first place, that led the provider community and for other advocacy groups to request that these changes be made. This extension is ultimately just going to extend what already is an overly bureaucratic process on top of other eligibility issues that are already going on. But this isn't the only one, Keith, because there's also a word that many people on the call probably have gotten sick of, because we talked about it a lot after, especially as it related to what had to happen in the states after the public health emergency, and that is the Medicaid redetermination. So the last large impact of $69 billion is the increased frequency of the Medicaid eligibility redeterminations. Why does this result in Medicaid losses?
Yeah, Eric, this one's sort of similar to a last couple that we've talked about. Really, this is more frequent eligibility redeterminations on expansion individuals to 6 months rather than 12 months. The non-expansion population stays at 12. The retroactive, you could currently you could go retroactive back 90 days or 3 months. The look back period goes to 30 days for expansion patients and 60 days for non-expansion. So what happens here is more frequent determinations and shorter eligibility periods are going to take patients that we feel are even maybe eligible. It's going to take them out because of procedural issues or so on and so forth. The increased workload, think about the projects we've just talked about and the increased workload at the state and your facilities in making sure eligibility is covered. So we think it's going to create backlogs and all kind of issues. Once again, could contribute to uninsured because patients will just drop out. So with that, we've covered some bad things. Really, we've covered probably around billion. No, it's hard to say billion, but $800 billion. So the one good thing really is the Rural Health Relief Fund. And in the Rural Health Relief Fund, as everyone probably knows, is that it establishes $10 billion a year for 5 years, and it is for rural facilities. And the first thing to happen is the states have to do a one-time application by the end of December this year, which I'm sure the states are probably jumping on that, trying to get moving. But in their transition plan, they've got to have things like how to improve access to healthcare providers, improving healthcare outcomes, increasing financial stability, and so on. And this is all in the rural environment. Okay, so this money is going to rural to try to help them out. And rural doesn't just include hospitals, it includes RHCs, FQHCs, community mental health, health centers receiving 330 grant money. And in this, 50% of the funds are just being allocated by CMS on a state-by-state basis. I'm sure each state looks at that differently, some fondly and some not. Then the other 50% is going to be allocated based on your state's rural population and a census tract, maybe the population of rural facilities in a state to total U.S. I mean, that's a nice statistic, but is that a way to do it? The deemed dish or whatever the administrator feels is needed. So when you get this, though, this is not just play money to go to the rural entities. There are measurements. There's 10 measurements, and the states have to use at least money towards at least 3 of these measurements, like improving prevention and chronic disease management, maybe access to opioids, substance abuse, mental health treatments. So retaining clinical workforce in rural areas. So there's strings tied to it that you've got to have outcome measures. It may cost you dollars. Once again, more state record keeping. And I think the states can only spend themselves 10% of this. They can take some of the money. So, at this moment, this is going to be up to first you got to apply, see what you get. Then each state is going to have to determine how the money goes out. And so we'll know later on this year, maybe first of next year, how this is really coming out. There's a couple other cuts that are out there that didn't make it in this that I think are worth you given us a little information on, Eric. And can you tell us about those?
I'll start with the one that has been in most of the reconciliation bills over the last decade, and that is Medicaid DISH. So if you've followed, Affordable Care Act had some pretty big cuts to Medicaid DISH to fund that program, and almost immediately the provider community had requested that be postponed, and it has been postponed several times. Only in timing, the amount to be collected just keeps growing, and it's just a big wave that's sitting out there ready to hit. And it was not included in this reconciliation bill, and it seems that there's a lot of comments out in the industry that this might be the end of the road for the delays to the Medicaid DISH. So it's definitely something that we've been following, which could be a big hit to safety net hospitals in several states across the country. The other one that's getting a lot of discussion is Medicare sequestration. And right now we already have Medicare sequestration as PAYGO that came in during the Obama administration to help pay for deficit spending. And this bill, because it increases deficit spending, is supposed to trigger an increase to sequestration from 2% to 4%. It might not sound like big numbers, an additional 2%, but that first 2% has already made reimbursement of the Medicare program pretty much a below cost reimburser for many hospitals across the country. It's 98% of Medicare is just simply not enough, and 96% is going to be even worse. So hopefully Congress is able to solve that issue. And then the other one that's not a Medicaid or Medicare, but that is the Affordable Care Act's enhanced premium support, which had been extended during COVID. That is now set to expire this year. And in those cases, the anticipation is that there will be families that will find it hard to maintain coverage in the exchange, or might actually get less coverage through the exchange, and might have a harder time with some of the cost sharing aspects of changing their insurance. But I think overall, we do anticipate that is going to go away, that we can expect that that we'll see increase in uninsured or underinsured as a result of that, and some of these other measures. We'll see an increase to bad debts, charity, rev cycle process is going to be a little bit more convoluted as hospitals and providers deal with the eligibility issues. And it's probably a good time for hospitals to explore to re-explore their financial assistance policies in light of the changes that are coming down the road here in the future. We have gone long here. I hope we have not deflated everybody's moods here this morning, but it's probably a good time to turn it over to our tax experts.
Thank you. I'm Mary Antonetti. I am a tax partner who works in nonprofits and healthcare. Excuse me if there's any background noise, because when the gentlemen were speaking, it was a nice sunny day here. It started to thunder and lightning, and the sky went dark. Not saying they didn't like the provisions, but it did kind of change that mood. So following up on what they were saying, and speaking firstly from a nonprofit hospital perspective, in the Northeast where I sit right now, we are finishing up our 9/30 year end, so we are right in the middle of Schedule H season, looking at them right now. If you're going to have a Medicare shortfall and less people are going to be insured, then in theory and probably in practice, you're going to end up with more bad debt charity care. I think the key is to make sure that it doesn't end up as bad debt, but does end up as charity care. Because we know there's a lot of scrutiny over the Line 7 charity care community benefit percentages, and we want to make sure that you can get those numbers specifically quantified into that line. It's a small concession, right? You're still out the money, but at least if we can show that that reduction is going up and your percentages are going up, then there will at least be some sort of benefit to these changes. I think a couple things to highlight about are going to be your policies. Make sure you're looking at your policies. Make sure if you don't have presumptive eligibility, I know many of my clients have said that they're going to look down now and do presumptive eligibility because people who would not have qualified because they hadn't filled out the information to fill out the FAP, if you can presumptively qualify those people, so you know they've lost Medicaid and you now know that they can qualify, then you can get them into the charity care numbers. You also might want to look at your expansion. If you're shrinking the amount of population that's on Medicaid, do you want to change your financial assistance policy in such a way that you're going to pick up these different things? So I think just my keynote here is you're going to have to look at your policies. Obviously, we're here to help you and other people are here to help you. But what you want to do is think about it now, because you don't want to get to the end of next year and find out that you have a really big bad debt expense that's not going to help you in your charity care percentages. For non-hospitals, you obviously don't have the same thing as the Schedule H and the community benefit reporting, but everyone does look to charity care. So I think it may be a point where we're going to start to relook at your 990s. And if those numbers are going up and up and up, is there a way for us to get that into the narrative? So at least we can show to the world all the benefits that you are providing. I believe next is a polling question. So
all right, thank you, Mary. Oh, go ahead.
Okay, I was going to read it, but if I wasn't supposed to, that's fine. But are you a rural provider as defined in section 71401, D1 through 7? Yes, no, don't know, or not applicable to my organization.
All right, we'll do a few more seconds here and then we'll get this closed out. Just a reminder, you do need to respond to at least 3 of the 4 polling questions. And here are the results.
All right, in respect of time, I'll go ahead and advance us to our next topic. Keep in mind the Tax Act really only had one tax provision that's specific to a tax-exempt hospital, for example, tax-exempt long-term care organization, and then all tax-exempt organizations generally. And that's a change to the definition of covered employee with respect to the excise tax on excess compensation. They've expanded that definition to include any current or former employee that was paid over $1 million. So it's not just top 5 anymore. That's what's key. When this first was passed with tax reform, any employee that was in the top 5 that was paid over $1 million, you needed to consider a covered employee. And then once a covered employee, always a covered employee. Now you still once a covered employee, always a covered employee, but it's not just the top 5. And I'll talk about some just things to think about and some planning as we get further into the presentation. But I just wanted to kind of state the change. And then in terms of that change, that's an amendment to IRC 4960. And again, it's a current or former employee that's over $1 million. Does away with the top 5. It could have some considerations and consequences. And again, we'll talk about that here in just a little bit future into the presentation. But keep in mind, the exception for remuneration for medical services remains, as well as the volunteer exception. And I know that medical services will mean a lot to those of you that are joining us this morning or this afternoon, just because we are specific to healthcare organizations as we're speaking today. All right, with that, I'm going to turn it over to Chris and Mary.
I'm
Thank
back.
you. You are back.
I am back. Thanks, Wendy. A few things to note. We just said what the implications are to some of these revenue cuts on the nonprofit organizations and Schedule H and what we should do about it. What about the taxable organizations? I think for cash basis taxpayers, it's probably the most obvious. Obviously, if you're not getting paid, you're not collecting the revenue, it's not going to be taxable. That's sort of the easy one. For accrual basis taxpayers, you're going to have to keep in mind that you're going to be weighing the actual write-off of the bad debt expense. So building up your allowance isn't going to help you because you're going to need to actually write off that bad debt expense in order to get the deduction. So I think what you're going to have to really do is spend time thinking about that. I know you don't want to leave the money if you possibly could go after the people, but if it really is a bad debt, then you may want to start to write those off to bring down your taxable income, especially if your revenue is high that year. Bad debt expense is going to increase. I think we're all anticipating that. The real question is, can you get some sort of benefit on your taxes with a deduction for that? Also, keeping in mind, if you are an unaffiliated healthcare organization, meaning you have no affiliation to the not-for-profit, while you still don't want to come across as, going after people who really can't afford to pay, you do have a little more flexibility. If you are an organization that is affiliated with a nonprofit organization, their charity care policies are probably written into some joint venture agreements that you have in there. So you're going to have to make sure that if they're changing their charity care policies, you also understand that, because there could be an implication to the for-profit affiliated with the not-for-profit organization.
Along with that, Mary, before we move to the next slide, an area that we've seen a lot of concern over the last 2 years has to do with transactions of for-profit entities where the revenue recognition on the books has not always matched the cash coming in the door. And so that waterfall calculation to make sure that there's some sort of reconciliation and that the receivables are in fact being collected is a critical aspect to these healthcare organizations. In a transaction environment, let's say that the multiplier is 10x of EBITDA, the impact to transaction price can be quite large when these items are off. So if you look at historical models and say, well, this historically has been what our reimbursement and compensation rates have been, and you're not doing a really diligent job on the back end of verifying that through some sort of waterfall calculation around subsequent receipts, you could run into some problems here if there's higher uncompensated care, higher bad debts that are not being identified early in the process. And so it's something that we expect to come up in due diligence around transactions. I say expected to. We're seeing it already. We're seeing this come up in the due diligence context already. And it's an area that has a significant impact on final purchase price. So something for organizations to keep in mind.
Strategies. There are many. I think, Wendy, why don't you start with some of your Schedule H planning strategies?
Great, thank you. I did just want to mention a number of things. I think this is a good time for hospitals or any organization that's required to file Schedule H due to having a hospital license in your state, which, keep in mind, varies by state what that definition of having to have a hospital license means. Just to kind of reevaluate and take a look at all the things you're doing and your community benefit reporting, including that Schedule H. Keep in mind, the IRS doesn't have a percentage threshold that they are expecting to see for you to maintain tax-exempt status. However, we all know that tax-exempt hospitals have been under scrutiny. They remain under scrutiny. Just because there wasn't specific tax provisions in the recent Tax Act doesn't mean there won't be in the future. We are anticipating that before the end of the year, there potentially is going to be more tax provisions passed and implemented. And there continues to be scrutiny on hospitals. So even though they don't have that expected percentage for community benefit on Schedule H, the thought is, or the scrutiny has been tax exempt hospitals are getting a bigger tax break than they are providing that community benefit and charity care to the community. And so you really just want to make sure you're capturing every possible thing that you can. And keep in mind those tax breaks, that's not just income tax. You know, there's property tax exemptions that you are able to take advantage of, you know, some federal unemployment tax as a tax exempt organization, perhaps some sales and use tax. You know, there's a number of different taxes within that realm that you're getting the benefit of. And so just the other thing I just wanted to mention is keep in mind with Schedule H, that's a catch-all for any licensed hospital that's required to file a Schedule H. It's not specific to children's hospitals or critical access hospitals. And we have some clients that are treatment centers, and because of their licensing in that state, do have to file a Schedule H. So if you're just looking at Schedule H's, you really want to come up with your peer group first to look at their Schedule H's if you're doing comparisons. And with that, I want to make sure we have plenty of time. And I understand I lost you for a second, or you lost me. But Mary, did you have anything to add to that? Or Chris, you want to chime in on some of these other tax strategies?
I'll chime in. And Wendy, I heard you the whole time. And if anybody missed a moment, I'm sure it was profound. So one of the things that I hear and I pay a lot of attention to is when leaders in both political parties start to talk about an issue. And the community benefit is something that we've heard from congressional leaders in both political parties as an area of concern, where from their perspective, whether that's right or wrong, there's a perception that there's significant inconsistencies in how certain tax exempt organizations benefit the community. Some of that may in fact be reality. Some of it may be what's demonstrated on the filings that are available. And so it's not always that is in fact the case, but it may be what's reflected on these tax exempt filings, which are public record. Anybody can look them up. So it's something that I try to talk with organizations about in the broader context of healthcare, whether you're tax exempt, whether you're private equity, whether you're venture capital backed, whether you're independently held. I think it's important to understand that both political parties have concerns that everybody be vested in ensuring high quality care at price points that are sustainable. And if you're hitting on those two issues as a strategy, as an organization, I think you're going to be in a better position in the long run than an organization that loses sight of one of those characteristics. We hear it quite a lot from policymakers, but we also hear it from leaders within the healthcare industry, you know, the best in practice that we see. Just a high level on the for-profit tax side, a few things we want to address. One is that previously, starting in 2022, there was a limitation on the ability of organizations to deduct interest, especially if they were highly leveraged and the companies they were operating were not very profitable. We saw this a lot with startup companies. We've seen it a lot with some joint ventures, and we've seen it a lot with institutionally backed healthcare investments. Institutionally could be health systems, it could be private equity, it could be venture capital. And the new law is going to allow for greater interest deductions. Previously, we would see organizations that might report a $50 million loss for GAAP or book purposes, but on their tax returns, they could show $20 or $30 million of taxable income and have to pay tax as a result of that. That's how big the swing could be on some of these adjustments. So this is significant, and it's very helpful for those organizations. Mary, there's some state and local tax implications we won't be able to go through all the nuance for, but do you want to hit it on a high level?
I do, and just one comment on the interest. Keep in mind, some of the organizations out there might have already made some certain elections under 163J to opt out of it because of the type of healthcare organization they were. It's usually related to a rental of real estate. So this is going to help a lot of the organizations that were not otherwise helped in the previous bill if you could have made one of the exceptions. Just really high level on state and local taxes. The state and local tax deduction was raised from $10,000 to $40,000 on the individual tax return, which is really helpful, but it does also phase out between 500,000 and 600,000 in income on the individual return. So it is not going to be a one-size-fits-all strategy of whether you want to opt in or opt out of PET taxes in the future. You know, if you are a standalone smaller entity with owners that are not going to go over the $500,000 or $600,000 mark, there may be a great ability to opt in and get a full deduction. Likewise, if you are a really large organization, maybe opting in is going to get you the better federal deduction, and a little bit of taxes that we're paying because of the scale back is fine. But then there's going to be a sweet spot in the middle where it makes sense not to opt in. So that's something you're going to have to work with your tax advisor on. But just because you made elections last year doesn't mean you're going to necessarily want to make the same elections this year.
Mary, and we have one final polling question. I want to make sure everybody gets CPE credit. So let's move to that. Amy?
All right, thank you. So the last poll is, do you anticipate the states where you serve patients will absorb some of the federal funding reductions in order to maintain payment levels to providers? And then your options are yes, no, I think my states will help some, or D, not sure, or not applicable. And while you're responding to that, if you would like a copy of today's slides, you can download them now from your console, but we're also sending them out via email tomorrow along with a recording of this webcast. All right, we'll do another 5 seconds. We're getting short on time here. And here are the results.
Thank you. I was on mute for a moment. So we have quite a few people who don't believe that the states will be able to cover all or some of the funding cuts, which is in line with our discussions around the country with healthcare organizations. We're going to advance to the next slide. We have, there's a lot of takeaways from today's conversation, but I think one of the key ones is to make sure that you're talking with your strategic leaders in your organization, talking with your outside advisors, whether that be CPA firms like us, your attorneys and others, and taking a hard look at your policies and what your plans are over the next several years, and make sure that you're factoring these adjustments. Here is quick conference in November in Las Vegas that I want to make sure we highlight. On this slide, we have a number of other webcasts that are coming up that are available to folks. Continuing discussions around the One Big Beautiful Bill Act, including a deeper dive for tax-exempt organizations that I believe, Wendy, is happening later today. It's our 30th anniversary of the Executive Healthcare Conference. On November 12th, it's the Women's Executive Healthcare Leadership Forum. November 13th is the day that most of the presenters will be there, and most of the content for the conference will happen. And on Friday the 14th, for half a day, there'll be an economic forecast. It's a great opportunity to network with C-suite individuals. One just quick plug is that the registration is discounted through August 21st. So beginning on August 22nd, it costs just a little bit more to register for the event. So if there are those who are interested, please go ahead and scan the QR code and register now. And with that, I'll turn it back over to Amy.
All right. Well, thank you all for a great presentation today. I also want to thank our audience for being engaged and submitting your question to help guide today's conversation. If you have further questions or comments, please reach out. You can drop a note in the Q&A window now, or reach out to our presenters directly. And then if you met all CPE requirements, your certificate is available to download now in the CPE progress window. A copy will be emailed in 2 weeks as well. And then finally, here's a link to a survey for today's presentation. Your feedback is always appreciated. And again, thank you for joining us, and take care.
Thank you, everyone.